Great. Amit, back to you, and I would like to dwell on this further because, if anything, let's talk about another drug, and then maybe to put into perspective, there's also pembrolizumab, which is, if anything, like quite evolving also in regard to HCC, and there's, I think, Keynote 224. Tell us about Keynote 224, and then we'll talk back about Nivo.
Yeah, so Keynote 224 also evaluates immunotherapy, but this one with pembro in the second-line setting. Phase 2 study, just like Checkmate 040. And similar to Checkmate 040, shows very promising durable response rates, right around the same mark, around this 15%. So if anything, I think it reinforces now with 2 phase 2 studies that you can see this in uncontrolled settings in terms of immunotherapy having very good response rates. Like Checkmate 040, where we're waiting for 459 data, Keynote 224, we're also waiting for the phase 3 data in terms of Keynote 240. So I think that both very promising phase 2 uncontrolled settings where we're waiting for larger phase 3 data in a comparative fashion.
Absolutely, and if anything, the Checkmate 224, if anything, it's going to be, the Keynote 224 is going to be more like pertinent to the second line, while the Checkmate 459 is more in the first line. But let's go back to the question, and I'll ask Peter. So it's good to ask this question, even though some people in the beginning are like, wait, you can't ask that question. But let me ask you, theoretically, let's assume, for argument's sake, and only to understand what does that mean, because we spoke quite a bit about those points. Let's say Checkmate 459 does not really show an improvement in outcome for the Nivo versus sorafenib. What does that mean? How do you interpret that? Our argument, you know, we're not saying this is what it is. This is just a good exercise to talk about that.
It would add another level of complexity to our discussions. The expectation is clear. We believe from what we have seen it's a positive trial, but your point, Ghassan, is extremely well taken. There's a lot happening after the patient is off track, and that might heavily influence whether it's crossover or other trials. So the second and even third line treatment options, which are there and haven't been there in the past, will certainly impact OS, and post-progression pattern is extremely relevant and might be required in order to understand what had been happening, whether it's a positive or negative trial. Nevertheless, I'm very optimistic, because when we reconsider the situation at ASCO this year in Chicago, that has been such an active field. And I mean, you have been approached by everybody about not only doublets, but triplets. and so the combos are already there. You know that there is the Himalaya trial, the IMbrave 150 trial, testing different combinations. And whether or not single agent matures into an effective therapy, there will be more around, and this field is already moving very, very fast.
No, I totally agree. If anything, again, we put the question only for argument's sake. And interestingly, I don't think any of us are questioning the value and the efficacy of the checkpoint inhibitors. And here's in reference, for example, to nivolumab. But I think what we are bringing up is exactly what Riyad brought up as a start of a discussion here a little bit earlier, is that what happened to the patients during their whole sequence of therapies. And could it be that they received checkpoint inhibitors after sorafenib on that trial of sorafenib versus Nivo anyway? It is possible. And if anything, it really brings into question is what are the timing of the therapies, and will it matter? It appears to be, based on our conclusion from the discussion on TKIs, yes, it might matter. And a great example of that is the Rigo followed by sorafenib. On the other hand, it appears checkpoint inhibitors, it will not necessarily matter much where they come into play. And this is fascinating, because to bring into question for the Nivo sorafenib, there's a lot of opportunities after the Nivo sorafenib that patients might get, while for the pembro versus placebo, they already received something in the first line, and this more second line. It will be fascinating to see. We're not, again, really aware of any data for any of those studies, but it will be nice to really bring those questions into play, to at least learn from at least or do those discussions, and see ultimately what will be the end points, so we can figure out really how to interpret those endpoint questions that we brought a little bit earlier.